Welcome back, kids and coaches, and today we are jumping into the spine here. So we are into Unit 8, Chapter 20, so we are in the last end of everything here. So first off, I want to just go over the anatomy of the spine real quick, and then we will kind of move on from there. So with the spine, you have really 5 segments to it, but only 3 we really kind of worry about too much. So you have 7 cervical vertebrae, you have 12 thoracic vertebrae, and 5 lumbar vertebrae. Then you have a sacrum and a coccyx. So your coccyx is your tailbone. So the vertebrae that are movable are the cervical, thoracic, and lumbar ones. So we have 24 of those. The sacrum and coccyx are fused, meaning they don't move. Now, the sacrum will move a little bit with the pelvis, but we're not so concerned about that. But the sacrum is 5 fused vertebrae, and the coccyx is 4 fused vertebrae. So you have 9 fused vertebrae there. What's more important is the vertebral column acts as the protector for our spinal cord. So the spinal cord is part of our central nervous system, which means it allows us to take signals and send them out to the body, and then our body does stuff. Now, one little trick you can do to remember how many vertebrae you have in each segment is you eat breakfast at 7, you eat lunch at noon, and you eat dinner at 5. So 7 cervical, 12 thoracic, 5 lumbar vertebrae. All mammals have 7 cervical vertebrae. So that means everyone from us to giraffes all have 7 bones in their neck. The way you tell when the neck stops and the thoracic vertebrae start is that the thoracic vertebrae all have ribs attached to them. So if it has a rib, it's thoracic. If it doesn't have a rib and it's up top, it's cervical. If it's down low, it's lumbar. You have plenty of muscles that help to move your spine. The ones we want to really focus on here is this group here. This is your Erector Spinae muscles. They're a group of 3 different muscles that come and form together, and they allow you to keep your body upright, and they allow you to go back, and they also allow you to flex laterally, or they allow you to move laterally. So your Erector Spinae muscles help to allow you to stand, that along with your glutes there. Now, I want to get into the actual stuff we want to talk about here, so the injury side of things. Now, when you have a mechanical issue with your spine, it means that something has happened where the spine is moving and it needs to stop moving. Sometimes that takes surgery, sometimes it takes exercise, sometimes it's posture, but there's 3 main ones we're going to look at here. We have scoliosis, kyphosis, and lordosis. I'm sure many of you have heard of scoliosis, but all that scoliosis is a lateral movement of the spine. So normally, your spine should go straight up and down. When you have scoliosis, your spine shifts one way or another. It can have multiple curvatures. You can have scoliosis anywhere in your spine. Most common is in the thoracic spine though. So where the ribs are, that's the most common place to get that. If you catch this early on enough, like in life, you can usually wear like a back brace and your body will kind of grow into it and straighten out as you grow. If you don't have any treatment and you get into adulthood where your body stops growing, usually the only way to prevent further or farther movement of the spine is to have a surgery where you get your spine essentially fused together. Now it's going to limit your motion a lot, but at the same time, it's going to prevent you from having more complications from the scoliosis. Now, kyphosis is where you have essentially a humpback. Kyphosis means the thoracic spine bow outward. So if you had kyphosis, you would see on your back here a hump forming, and you would be bent over. This used to be called a dowager's hump. You may see this more often in like the older population, but mostly what you'll see is this comes from disc degeneration and then poor posture. So the more people lean over at their desk, especially, so the more you're doing this, the more you set yourself up for upper back and neck pain, as well as the potential for kyphotic changes. If you have kyphosis, pretty much what you would do to try to correct that is bracing and exercise. Sometimes you can have a kyphoplasty. That's where you would get a physician to go in and he would actually inject a cement straight into your bone, because if the bone was crushed and you put that cement in, it would come back out and give you your normal posture. Only problem is we're finding out that long term that's really not a good solution. And actually the American College of Surgeons has said that kyphoplasty really should only be a last measure that you do, like last ditch effort when everything else has failed. So really you want to try to avoid that. Now lordosis is when you have a curvature inward, and this is in your low back. So kyphosis, you have a rounded upper back. Lordosis, your belly sticks out. So your spine goes too far in. What the big problem that can be here is that you can actually get nerve impingements. So here would be where your spinal cord is. And with this being pinched, it can actually cause some constriction on your spinal cord, which can cause pain, numbness, tingling, loss of sensation, loss of movement, all that fun stuff. Additionally, because the lumbar spine are curved in such a way, they're going to have a lot more pressure on your intervertebral discs. So the pieces of cartilage you have that are going to separate your bones from each other, those can essentially get pinched together, causing additional pain. The one thing about this is that really the only good treatment for it is to be conservative, meaning using like primarily exercise, stretching. Occasionally there's like decompression therapies that may be somewhat effective. But if you get this, or if you get kyphosis, you actually will lose height. You can lose anywhere from about 1/2 inch to 2.5 inches, depending on the severity of this curvature. Now, if you have stenosis, this just means you have a narrowing of your spinal cavity or your spinal canal. For any of you Dallas Cowboy fans out there, Michael Irvin, who was their Hall of Fame wide receiver in the late 80s to mid to late 90s, had spinal stenosis, and it ended up making him retire early. But what happens here is when you have stenosis, the canal where your spine or your spinal cord runs through becomes narrow, and it can impinge on it. So you see how this is normally what your spinal canal should look like. This is what happens when you have stenosis. So you have compression on the spine there. Your spine is only about as big as a pencil. And it's probably about good. Well, I shouldn't say as big as a pencil, but it's as wide as the circumference of a pencil. So really, if you look at that, that's like less than the tip of your finger. But that's all the width is of your spinal cord. So you can imagine if you have something compressing on this, you're really not getting a whole lot of free movement out of there no matter what you do. Stenosis is very tricky because this is a degenerative condition. When you get stenosis, you don't just say recover from it. You can't just correct it. There's no single surgery that's going to just fix it. So when you have disc degeneration or when you have bone degeneration, the best you can do is do things to slow or stop the progression of it. It's similar to arthritis. Once you get arthritis, you always have arthritis. There's no going back. But you can use different treatments, exercise, medications, all that to help with slowing or stopping the progression of it. Same thing with stenosis. Now, some of our traumatic injuries we would see, um, if we get a dislocation or a fracture in your neck, that's usually going to be a very traumatic injury, or whiplash. Um, you don't really get whiplash in team sports. You may, like, there is a potential chance for you to get it. Say, like, if you were being tackled from straight behind, you could potentially get whiplash, but that's very uncommon. More likely than not, in any kind of collegiate sport, you're going to see muscle strains in the neck and upper back. That's going to be the biggest thing you'll see. A lot of times, these muscle strains will be the result of having posture where your head sits forward. So your head should sit so your ear is straight above your shoulder. And even when I sit here, I'm not perfect, but I'm relatively close, I'd say. Your head as an adult weighs roughly 10 pounds. Every inch you lean forward puts an extra 10 pounds of stress on the base of your neck and your upper back. So you can imagine if you're leaning all the way forward, no, you're talking several inches there. So now, instead of having just a 10-pound bowling ball in your head, now you got something that's like 50 pounds. That puts a ton of strain on your back. Think of it of like if you were a kid wearing a really heavy backpack, what that can do to put strain on your back and neck. That same kind of thing happens if you tilt that head forward. So it's always a good idea to check yourself, make sure your head is tilted backward. That way you'd have a lot less stress put on it. A couple other injuries I just wanted to go over here. Torrticollis is a nerve injury. Well, I shouldn't really say an injury, but it's a condition where you have a tilting of the head. And you either have a lateral tilt or sometimes you would see a rotation. But either way, if you tried to put your head straight forward, it would either tilt or it would twist. Usually this happens when you're very young and it'll typically resolve itself on its own. Occasionally you do need to have some sort of treatment for it that'll help with straightening out the neck. Usually that involves, like, say, some sort of like spinal decompression, or usually like using an anti-inflammatory specific for your nerves. But usually this is something that resolves itself with little to no complication. If you have a pinched nerve to your brachial plexus. So your brachial plexus, a plexus is a group of nerves. So your brachial plexus actually runs from C4 to T1. So there's 1, 2, 3, 4, 5, 6 nerves that make this up. Your brachial plexus goes from your neck, underneath your collarbone, past your shoulder, and then all the way down into your hand. If you have an impingement or a compression on the roots here, while you may see pain or some other symptoms like in the back or upper neck, your biggest area where you're going to have disability is going to be in your shoulder. If you get cut off up here, you can't get anything to flow downstream. So your shoulder is going to be most affected. Now, if you saw, or if any of you watched the show All American, and the only reason I know this is because my wife has been binge watching this. I think it's in, well, it's in one of the 2 seasons. The lead running back guy gets shot in his upper left quadrant. So he gets shot, I'm sorry, his upper right side of his body. So he gets shot like right underneath the shoulder and ends up having a nerve injury. Well, that nerve injury is an injury to his brachial plexus. And they show him not being able to squeeze someone's hand. And while that potentially may happen, your more accurate issue is going to be if the shoulder moves. So when they have his shoulder moving, but his hand isn't functioning, that's actually not something that would happen. You can't have the injury occur here, have all of this work fine, and then have this not work. So you're going to have symptoms close to the site of the injury. Now, one exception to this rule, and I will bring this up right here, is when you have sciatica. So if you have sciatica, what that means is that you have a nerve impingement on your sciatic nerve. And it can be impingement from the bone. So your bones in your lumbar spine can be impinging it. There's a muscle over here that'll overlap. That can potentially impinge it. If you have an impingement on your sciatic nerve, what can happen is if it gets really, like, say, hit, or it's really aggravated, you can feel, like, say, a shock wave going down your entire leg. Now, the difference between the two is that with the sciatic type pain, that pain you would have is just like a quick instant. It's not really something that's going to be debilitating, in most cases, but you could feel it all the way down. This is because your sciatic nerve has multiple branches, and then it has multiple points where it moves or it separates out into other branches. So it actually branches up, then comes together, then branches out again. That's why you can get that sciatic pain all down your leg there. Now, disc injuries. If you have disc injuries in your intervertebral discs are these things here, but they're pieces of cartilage that separate your vertebral bones from each other. So that you should see a space in between your vertebrae if you took an x-ray, because that is your intervertebral disc. It's not really going to show up on an x-ray because it's cartilage. So you don't really see cartilage on an x-ray, but it's there to keep the discs from compressing against each other. If you get any sort of injury to these or degeneration with these, you'll see that these discs can cause this space here to compress. So you notice how there's very little room here compared to, say, here or here. If you get a disc herniation, now the contents of your disc actually rupture open and leak out. So it would kind of be like if you had one of these like cool pads. So nice little Park University one. And you notice how there's all these bubbles in there. And if I move these bubbles around, you can see how I can make it so that they all go to one side, or I can flatten it out and everything is back to where it was. It doesn't matter how I squeeze this, how I move this. The bubbles still all stay within the contents or the package here. If I were to cut open this and then squeeze, these bubbles would all shoot out. When you have a herniation in your intervertebral discs, that's exactly what happens. So your intervertebral disc looks like this. So it's kind of like a solid donut. This center piece here is called your nucleus propulsus. And that floats around depending on where you move. So if I move all of these over to one side versus another, that nucleus will shift over to accommodate that. If I tear this, so if I had a tear here, this nucleus would leak out. So these bubbles would fall out. Well, if they fall out and they hit your spinal cord or in your spinal roots, that's going to cause problems. A lot of times people will have even slight herniations, so like a bulging disc where you have it like a little bit leaking out and have no issue. Or the disc itself could actually move one way or the other, but you may not have issues with it. It's only when that disc runs into something, specifically a nerve, is when you get problems. The term for that here is spondylolisthesis. I know it's a mouthful, but just remember that as a disc herniation. Now, this thing here, ankylosing spondylitis, this is really bad. This is colloquially known as bamboo spine. What happens here? So this is a degenerative progressive condition. You notice you can see these are all the discs, and notice how they're compressed inward. So now it's almost like I take this and I'm pushing everything towards the center. Well, now what's happening is that these pieces that have empty space are now getting sealed off. So even if I try to reshape this, they're not going to go back to that side that I moved it from. What's happening is the bone of your spine, so your actual vertebral bone, is building over your intervertebral discs. So instead of having those nice gaps in between there, your spine becomes all fused together. When that happens, you can't move. So you cannot move your spine anyway. You are stuck standing straight up and down. You can't fix this. Once those bones fuse, that's it. You are stuck with what you have. The one person that I can think of off the top of my head that has this, that you may know, is Mick Mars, and he is the lead guitarist for Motley Crue. But yeah, he has this, and it's not progressed terribly for him. But when that does fuse, you lose virtually all mobility. So you can no longer bend over. So doing something like even tying your shoes becomes extremely difficult. I've treated one person who had this when I was working in orthopedic rehab, and pretty much his back was like a washboard, straight up and down. Now, what was okay about that for him was that he didn't have his back set forward or backward. So his back was actually straight, meaning that he didn't have compression on his spinal cord, and he didn't lose function in terms of making himself tilt forward or backward. If you tilt forward, the big problem with that is that it compresses your lungs. So now you're much more likely to get something like, say, pneumonia, which is not a good thing. And then last thing here, I kind of spoke about this already, is DDD. That is degenerative disc disease. That's also known as spondylolysis. So remember, when we talked about, actually, I'm not sure if we talked about it here, but lysis means breakdown. So you see the term lysis when you have, or when you talk about like energy metabolism. So glycolysis, proteolysis, lipolysis, all those mean you're breaking down carbs, fats, proteins. So when you see that term lysis, things are breaking down. For this, your discs are breaking down. This here is what disc degeneration looks like. So your discs actually wear away. When that happens, that's when you get bone on bone between the two. So there's nothing fundamentally wrong with the disc, like it's not herniated or anything, but it's just essentially dying. And this is a pretty common condition, and a lot of times it can happen when you either have overuse of the area and come as a result of like a traumatic injury. It can be something where you put too much wear and tear on your spine. And again, really only conservative treatments work really well with this. In very extreme cases, sometimes you could see either a spinal fusion occur to stabilize that spine so that the bones don't move against each other and cause that bone-on-bone friction. Other times you may also even see a disc transplant. So sometimes you actually get someone to get a donor intervertebral disc to put in there to spread those back apart. All right, so that is everything new here with the spine. And I will be seeing you all again here when we talk about the last two chapters.